Hi, everybody. This is your voiceover for microbial and infection control. And just some readings to look back on. Craven, chapters 20, pretty much that whole chapter. Really, this PowerPoint helps pick apart the important things. But like I said, Craven's always a great resource to look back on. And then Craven chapter 27, just pages 818 to 823 would be helpful. Okay, so how do nurses prevent the spread of infection? That's something we're really always thinking about as nurses, right? How do we prevent infection? It's a big one. It's something we are never going to stop hearing throughout our career. It's something we're always kind of not necessarily graded on, but kind of in the workplace. We're kind of always getting not necessarily watched, but made sure that we are providing correct hand hygiene, whether we're washing our hands with soap and water, or we're scrubbing in and out with the alcohol-based hand rub. So nurses prevent the spread of infection by that fancy term called asepsis, right? It's to make free of a disease-producing organism. And really, how do we do that? And we do that in many ways as nurses. There's ranges from very minimal to very, very high ranges of asepsis. Minimally, scrubbing in and out with the hand-based hand sanitizer, hand washing, wearing gloves, to wearing our PPE, personal protective equipment, gloves, masks, hair caps, to sterilizing any field. We talked about the germicidal wipes and wet times, whether it be alcohol or bleach, even, prior to giving any injections, rubbing alcohol on the skin prior to prevent infections there, cleaning Foley's with soap and water, and then we go to the full extent of the full spectrum with full surgical scrubbing asepsis. So that's like really scrubbing in to a sterile field and whatnot. We're not going over that for this time. But just to let you see how there's a full range of asepsis that we can do in the medical field. So what is a pathogen? It's really pathogens are microorganisms. They're bugs, they're germs, right? And they come into contact and enter our bodies, and they can be capable of doing a lot of harm to us. They can disrupt our normal body's routine. They can make us really, really sick, and they can disrupt our cellular process. And we talked a little bit about this in class about, how pathogens and microorganisms can cause severe sepsis. They can cause our inflammatory process to spike. They cause our bodies to fight. So sometimes, our bodies will start to break down our own tissues to try to fight off these microorganisms. And what word comes to mind when describing a serious infection? And I think I've mentioned it already. It starts with an S, but that's sepsis. What are some, that's a serious infection that can happen to a lot of our patients. You'll see in your clinical site and in your nursing career. What are some signs and symptoms of sepsis? Patients can present very feverish, right? They can have a very, very high fever. They can be tachycardic, meaning they have a higher heart rate than 100. They tend to elicit a low blood pressure or hypotension. And that is all due to our bodies fighting and causing that inflammatory process, and really what is happening in our bodies that's causing these symptoms to happen. If not treated, this can cause organ disruption, organ failure, and even death, depending on how severe. And this was just a picture kind of noting on how sepsis and really the inflammatory process occurs in our body. And we talked about this. So when a microorganism or a germ enters our body and we start to get sick, our bodies are going to start to fight. That's our normal instinct, and that's our normal process. So it brings out an inflammatory response. So when we have that inflammatory response, because our tissues are becoming inflamed, it causes what we talked about, like leaky vessels. And remember, our blood vessels, we want them to be nice and plump, and we want them to be full of blood and fluid, which helps our blood pressure stay where it should be. If we lose that fluid through these leaky vessels because of inflammation, we're going to lose a lot of the plumpness in our vessels, right? which is going to therefore make our hemodynamics and our blood pressure decrease, making our heart rate increase. So that's where these hemodynamic changes come from, especially when digging a little bit deeper into the inflammatory process and how sepsis works. So I just wanted you guys to have a little bit of background and thought on how, what happens to our bodies when we trigger an inflammatory response. And I really like this slide. It kind of gives you a nice little overview of what happens with the inflammatory process as well. So we have some sort of disruption because we have a microorganism entering our body. We have a germ making us sick, creating that fighting immune reaction, leading to that inflammatory response. Our tissues become inflamed. So what happens? We have all these fighter cells, phagocytosis, release of mast cells, macrophages. We have a lot of, fighters in our bodies trying to fight off this germ. So we have an army really trying to attack what is invading our bodies. But in the long run, we're not going to feel so good while this is going on. So again, our systemic effects, we're going to have fever, right? With sepsis. If we look at labs, our white blood cells are going to increase. We're going to feel tired and lethargic, malaise. Anorexic, we're not going to have the greatest appetite. Okay, and we talked about the hemodynamic changes, right? Heart rate goes up, tachycardic, blood pressure probably goes down, hypotensive. Really, our perfusion is lacking when this is happening, especially if we get into the severe points of sepsis. And we went through systems really, really quickly in class. If we were at the bedside of a patient, having a microorganism invading their bodies, how might we assess them? So, neurologically, we said that they could probably come off as very lethargic, possibly even confused, agitated. They'll have some altered mental status. If we go down to cardiac, so we just did neuro, now we're going to cardiac. How is their heart rate? Is it tachycardic? Is it higher than normal? How's their blood pressure? Are they hypotensive? Is it lower than normal? Meaning their perfusion is lacking, due to the inflammatory process and decrease in oxygenation going on. We went to pulmonary, right? Are they having any, adventitious breath sounds? Are they working a little harder to breathe for some reason? GI, are they experiencing a decrease in appetite or anorexic, nausea, vomiting, diarrhea? If we go to GU, how is their urine output? Typically, if we have issues with decreased perfusion and, infection, a lot of times our urine output is decreased, whether it be from dehydration or our kidneys are starting to feel the effects of the invading microorganism. So agents that cause infections, what are these microorganisms we're talking about? So we're going to first go over bacteria. They're a single cell and they live independently, and they're of course certainly capable of causing disease in humans and making humans very, very ill. And they're capable of initiating that inflammatory response, right? They can be transmitted through the air, food, water, soil, even sexual activity. And some examples of bacteria could be bacterial pneumonia, TB or tuberculosis, MRSA, meningitis infections, UTIs, all of which a lot of bacterial infections we know needs to get treated with some sort of antibiotic, right? And we'll get to that in a little bit. Other microorganisms are viruses. Viruses are composed of nucleic acids and proteins, and they're bound in a membrane-bound protein cell. They reproduce inside living cells. A lot of viral infections are more acute. Our body's defense mechanism hopefully fights these off a little bit better. That's why we don't tend to see a lot of antibiotics given for viral infections. Doesn't really help them a whole heck of a lot. So we're hoping that our body's defense mechanisms can hopefully fight off the viruses. sometimes we need a little bit of help. Some viruses are pretty strong. So for example, we have HIV as an example of a virus, herpes, flu. We know the big one, which we've been dealing with for a few years, is COVID, rotavirus. And then we go on to fungi. So these are single-celled, composed of molds and yeast. So that's kind of an easy one to remember. And some examples of these would be candida, vaginal yeast infections, ringworm, athlete's foot. And then there's parasites, and we have heard of these definitely before. And the parasites are multicellular. They live on other organisms. They can be spread by sexual contact. Really, even animals can carry parasites, insects. They can carry these to humans, even unsanitary conditions. Some examples would be malaria, tapeworm, scabies. And moving on to prions, which we don't really hear a whole heck of a lot of, or they're composed primarily of proteins, and they cause abnormal folding of proteins, especially in the organ, the brain. Abnormal folding of proteins within the brain itself, and unfortunately this can lead to brain damage. Neurodegenerative diseases on a high level. Most prion diseases are untreatable, and typically they're fatal, unfortunately. Common diseases of prions: mad cow disease, Creutzfeldt-Jakob disease. So we've heard a lot about multi-drug resistant organisms, right? Also known as MDRO. So what's going on is microorganisms can adapt to ever-changing environments, and they're always competing for survival, right? They're like strong little stinkers. They're trying to survive, trying to live, and they replicate. So new strains of microorganisms, can become resistant to treatment drugs. So once they get a little bit stronger, that drug's not even going to touch them because they've gotten a lot stronger with replication. And that's a steadily increasing problem globally. And we're dealing with that in the healthcare institutions all the time. This is kind of why, providers are very, they're a little bit hesitant sometimes on giving antibiotics, and they want to make sure they're giving the proper antibiotics just to make sure that this type of problem doesn't keep going on. So what happens, why this is going on with MDRO? We have overprescribing of antibiotics. That's definitely one of the reasons why we are probably having multi-drug resistant organisms replicate. Using inappropriate antibiotics, so they're not being prescribed for the correct spectrum of bacteria growth. They're not taking antibiotics as prescribed, so the patient may not be taking what should be, prescribed to them. And really something we don't think about is actually overutilizing antibiotics in more agriculture and our animals and farming. We don't think how much that gets ingested into our bodies of what we're taking in. And that link here just showed you a lot of examples of how many microorganisms there are causing threats globally for MDRO. So what can we do as healthcare professionals to help prevent this or make this better? Diligent hand washing, diligent asepsis, diligent hand hygiene. Also careful use with, if a patient does have, urinary catheters, making sure we're very aseptic, cleaning them, and being, very careful with any indwelling lines, especially central lines, ventilators, surgical incisions, just being very, very diligent with asepsis. Precise diagnostics and treatment for the infection. So how do we do that? How do we get that precise spectrum of what we need to treat this bacteria for? Yeah, CNS. So we need blood cultures or any type of culture that's going to produce the growth of the bacteria. We need to get down to the bottom of it so we know what type of spectrum of antibiotic we can prescribe the patient. Whether that be through blood cultures, sputum cultures, urine cultures, wound. We have to get down to the bottom of what we're going to prescribe. So again, this kind of relates, but appropriate selection of medication. What is the selection of the spectrum? Okay, is that correct? And is that going to help fight that microorganism? Is the dosing correct for the patient? How long are they on that? Has that been correct? And is the route proper? Okay, some patients may need to start off on IV route and then change to by mouth. So all of these things are very, very important when selecting the correct medication. Transmission of infection. So are we providing proper isolation precautions for certain microorganisms? And we'll get on to talking about that. And then judicious use of medication. So, making sure there's strict adherence. If there's an antibiotic, you take all of what's prescribed. And we don't want to overprescribe either. And what is the most effective method of transmission prevention? And I think we all know that, how important that is, but hand hygiene. I wanted to mention quickly that there is, we have healthcare acquired infections and we have community acquired infections. Something that we go over every day, especially in the hospitals, possibly in long-term care as well, depending. But these are things we actually we're monitored by insurance for, we're monitored by outside agencies, and hospitals get docked, especially if patients experience any type of healthcare associated infection. There is no reimbursement there. So this is a big deal to hospitals. So there is central line associated bloodstream infections, also known as CLABSIs. There are catheter associated urinary tract infections, also known as CAUTIs. You're going to hear a lot about these as you go through your clinicals and career. There's ventilator associated pneumonia, also known as VAPS. Surgical site infections, also known as SSIs. And there's actually just healthcare acquired pneumonia in general, which would be called HAPs. All of these happening in the hospital. That's why it's called healthcare acquired. And if you remember in class, we talked about what the time frame is from admission to when symptoms may start. And that is 48 hours, okay, if you remember. So say I was admitted, and now 48 hours later, I'm starting to show signs of a fever. I am definitely getting probably docked for some sort of infection, whether it be, one out of the 5 that we had talked about: CLABSI, CAUTI, VAP, SSI, HAP, whatever is kind of happening within the hospital. It's post 48 hours after admission. Community acquired is especially, it's just what it means, happening out in the community. And we, of course, as a hospital, do not get docked for those. But these are infections that are happening outside of the hospital and in the community. And that's the difference between healthcare and community acquired. I love this slide. I really want you to hone in on this slide and know this. But it kind of helps us really take a good visual look at how the chain of infection goes. And it really starts with our infectious agents. So at the top right there, you have our germs. See, there's 3 germs there. And there's, we talked about bacteria, viruses, parasites, fungi, prions, right? We talked about all 5 of those type of parasites. Those are germs, those are microorganisms. Then after that, so after germs, we move on to reservoir, which means where do the germs live, okay? And we talked about, how they get around. Where do these germs live? They can live on people. They can live on animals, insects, reptiles, wild animals. They can live in food, soil, water. And next, how do these germs get out? How do they leave the people? How do they leave the food, the soil, the animals? It could be via the mouth, vomit, secretions, saliva, cuts in the skin, blood, toileting, stool, all portals of exits. And then we move on to mode of transmission. Okay, now they're in their car and they're trying to get around, right? So how do these microorganisms transmit? And they can be from, direct contact to contact, hand to hand. I'm shaking your hand. I just gave off a pathogen to someone else. It could be from, a computer mouse I'm touching a computer mouse, and then someone's going to come over and touch the same mouse that I touched. It could be on toys of children, even in sand. We don't really think about that. It could be through droplet. So if someone coughs, talks, sneezes, that is projected, microorganisms are projected out into the air, and then someone else can inhale that. So those are the very, mainly typical things. They can be ingested, especially if there's something in food or water. It can most certainly be ingested into the body. And how do germs get in? So portal of entry, how are they entering the new susceptible host? It could be, via the mouth, ingestion, cuts in the skin, could be the eyes. And we learned that was very, very common when we were dealing with COVID, right? And then susceptible hosts, meaning who is a susceptible person? Sometimes it could be, babies can be more susceptible to receiving infections, children, the elderly, people with weakened immune systems, unimmunized people, really could be anyone. Any one of us can certainly get sick, but especially those more susceptible, for sure. So yes, mode of transmission was on the chain of infection. We're going to talk a little bit more. We're going to dig a little bit deeper into the mode of transmission. This is really important because many of our aseptic techniques and our PPE precautions may be different depending on what type of mode of transmission it is. Contact. This is the most frequent means of transmitting infections. Really, we talked about direct, body surface to body surface. That's like, handshaking, high-fiving, physical transfer. And then indirect is a susceptible person touches an infected thing. So again, that was the example of like the computer mouse. I just touched the computer mouse, and then someone else is coming to touch it, and now they are infected with whatever microorganism was on there. So that's more indirect. Some examples of contact transmissions would be staph, C. diff, conjunctivitis, MRSA, herpes. Next, there's vehicle transmission, which is, transmitted by way of the infected item. So it could be via food, water, non-sterile equipment. Common microorganisms for this is Salmonella, Legionella. Droplet is next. These are, when our mucous membranes are exposed to infected secretions of a person who may be talking, coughing, or sneezing, and we're within the vicinity of that infected person. Droplet is a little less on the spectrum. These microorganisms from droplet seldom travel more than 3 to 6 feet, so they don't go too far. They do not remain suspended in the air, but it's still something to be concerned about. We can get the flu by droplet. We can get common cold, pertussis. What's another one? Rubella. Rubella is a common one. So next we go to airborne. This is a little bit higher on the spectrum than droplet. These are fine particles that are, either sneezed out into the air, coughed, even talking. But when they're suspended out in the air, they can be suspended for quite some time. They can even get caught up in dust particles that can contain the pathogen. And they can travel a little bit farther than 3 to 6 feet of what the droplet pathogen can do. So with airborne, we do have to think about special air handling and ventilation. Really, we call these negative pressure rooms are needed for these type of patients, just to contain and remove the pathogen from the airspace. That's how long that can be suspended within the air. Some common microorganisms for airborne is, of course, tuberculosis, TB, chickenpox, smallpox, measles, and of course, COVID was the big one. And then there's vector-borne. So this can be either biological or mechanical ways to spread infection. Biological, meaning it is transmitted via living creatures, bats, rats, insects, and birds. And then mechanical is typically inanimate objects are contaminated, meaning that they are possibly indwelling lines that can be contaminated, meaning a lot of like healthcare acquired infections may come from mechanical vector-borne transmission. Central lines, Foley's, IVs, ventilators, even needle sticks that have been infected by someone else. So in the hospitals or any healthcare, facility, they really do their best. They try their best to provide their employees with protected exposure. I know, a lot of institutions now mandate mandatory vaccines, like the flu. We went through mandatory vaccines of COVID. Institutions provide needle safety, so they should always have sharp containers, especially in every room or wherever necessary that needles may be. Also, needle safety in general, not just sharp safety, but needles should have like a safety mechanism to them, whether it's like a retraction type of mechanism of the needle or a cap flips over the needle. There's all different types of retraction safety now for needles so we don't get stuck. Gloves. There should be a fair amount of hand washing stations on each unit to make sure that hand hygiene can be done. Hand sanitizer should always be readily available. I know at BMC at least there's one at the entrance of every room. Hopefully, this is a tough one, but providing warm water really helps kill the bacteria. And I know that's hard, that's more of a plumbing thing. And we do have hazardous waste containers too. So especially if we have bodily fluids or large amounts of blood, bodily fluids, they go into containers which are typically in dirty utility rooms and can be contained in these containers. So we're going to talk a little bit more about that fancy word asepsis. There is medical asepsis and surgical asepsis. Definitely a good, difference between the both. So medical asepsis is measures to take or reduce the number of microorganisms present, meaning using the clean technique. So we can use clean technique on intact skin or non-sterile body cavities. Surfaces of the mouth, GI tract, the reproductive tract. Infected wounds can have the clean technique, chronic wounds. And really what we're doing with the clean technique is we're doing hand hygiene, whether it be hand scrub or hand washing. And we're, definitely done in gloves. And depending on what's going on, we can put a gown on if needed, especially if we know that there's going to be some splashing going on. Possibly, goggles, but nothing sterile. So that's what we're going to talk about next. So there's surgical asepsis, meaning that there's a sterile technique. We have to use sterile techniques on sterile body cavities, meaning all organs and vascular spaces. We're using sterile technique when inserting IV caths, Foley caths, central lines, any operative procedures, and we're also using the sterile technique on clean wounds. You'll learn how to do this a little bit further into the semester. Usually surgical scrub procedure is done for the sterile technique and sterile fields are placed and drapes are needed. So it's a little bit more advanced than the clean technique. So hand hygiene, we're going to hone in a little bit more on that. Gloves are great, but they do not take the place of washing hands, right? And sometimes we, as healthcare providers, may forget that. But washing before and after putting gloves on is a must, scrubbing in and out. So nothing can be emphasized more in nursing other than hand hygiene. And again, you're going to hear this throughout your career. For washing hands, we're needing, soap and warm water. Or if we're using scrub, it's typically alcohol hand-based scrub. And why may there be poor compliance with hand hygiene? Sometimes there might be a lack of knowledge, lack of awareness on how we can kill microorganisms. Common misconception, again, that gloves can take the place of washing, and we do not want that to happen. We've seen people out in the healthcare facilities, they wear the gloves and they're putting the hand sanitizer in washing, rubbing that on their gloves, which again is wrong. We always want to, do hand hygiene, put gloves on, take gloves off, hand hygiene again, in between what we're doing. Sometimes just no time and understaffing. That may be why there's some poor compliance with hand hygiene, high workloads, inaccessibility to the sinks. Hopefully all units have pretty accessible sinks or hand-based scrubs, and skin irritation. Sometimes skin can be cracked, raw, and it really hurts. I know a lot of facilities now provide lotions for healthcare personnel. Okay, so this is really the CDC's hand washing guidelines, and when to be doing hand hygiene, and it's a lot. We don't think about this throughout, while you're on the job or on the unit, and it's a lot that we need to be, providing hand hygiene. So at the beginning and end of your shift, immediately before touching a patient, before performing any aseptic task, placing indwelling devices, handling invasive devices, handling bodily fluids, handling secretions, before moving from work on a soiled body site to a clean site, right? So if we're doing, if a patient has had an incontinent episode or a bowel movement, we would of course want to change our gloves, wash our hands before providing any other care to the patient. After touching any patient or their patient's environment, especially when you're leaving the patient's room, before administering any medications, after contact with blood, bodily fluids, or contaminated surfaces, immediately after each glove removal, we should be washing our hands or doing hand hygiene, and especially going in between patients. That's a big one. The CDC does recommend alcohol-based hand sanitizer. That's a preferred method of hand hygiene just because it's more accessible. It's a little bit easier. So they feel that, healthcare providers would be more apt to use the hand scrub. It takes a little bit less time. You can actually, scrub your hands on the go, right? So you scrub at the door. The foam comes out. We call it foam in, foam out. And then, on the go, you can be rubbing, scrubbing your hands. So you don't have to be, sitting there stagnant at a sink. So that's why the CDC kind of prefers the alcohol-based hand sanitizer. Is washing your hands, not preferred? No, it's absolutely a wonderful way for hand hygiene. It's just something that is maybe a little bit more quick and more easily accessible. Something else to think about, keeping fingernails more on the shorter side. If they're longer, bacteria can harbor underneath your nails. Or if you have acrylics, nail polish, that's a good place for bacteria to harbor. Or rings or jewelry, any type of jewelry, rings, bracelets, bacteria can harbor under there as well. So when is alcohol-based hand scrub not effective? And this is a really important one. And that was, C. diff, C. difficile, Clostridium difficile, norovirus, rotavirus. Those are the three big ones where hand washing is necessary to kill the microorganism. Also, if we were to wash anything within the patient's room or outside of it, more of a bleach type of wash is the recommended use for C. diff, norovirus, rotavirus. More of the germicidal, alcohol-based wipes do not kill the microorganism. And these were two videos. One was showing you alcohol-based hand scrub. One was also showing you hand washing. So you'll see this in all healthcare facilities. It's by the World Health Organization, the CDC, and this is the hand washing procedure. And you always want to wet your hands enough prior to applying soap. and you want that soap to cover all surfaces of your hands. And then it shows you, the correct procedure, rubbing hands palm to palm, interlacing fingers, um, backs of the fingers, opposing palms, rotational scrubbing of the thumb, scrubbing of the palm itself, and then making sure you rinse correctly. Always making sure you dry thoroughly with a towel and you use that towel to shut the water off. You never want to shut your water off with your cleaned hand, right? These are some of the examples you may see in the healthcare institutions. They may not all be from this company, but I know BMC uses these types of washes. So these are germicidal wipes. Purple tops typically are germicidal, more alcohol based, and they're pretty much the most common wipe we use within the healthcare institutions. The middle orange top, sometimes you'll see white tops, are bleach. Again, the bleach is typically just for, C. diff, norovirus, rotavirus. And then there's gray tops, which is a lot of times equipment actually needs their own type of germicidal wipes. Sometimes equipment can be broken or, destroyed because of the wipes that we use. So they need a different type of wipe for that. Always pay attention. It's really important to note the wet time of the wipe. Typically, there's 3-minute wet times. We talked about this in class, and if I wipe my surface down, and typically if you're wiping your surface down, it's going to look wet. You're going to want that to remain wet or, not touch that site for at least 3 minutes. That's what wet time means. You're not placing anything on that surface until 3 minutes or doing anything with that surface until the 3 minutes is up. That's how we know that's been properly disinfected. So we're going to get into a little bit of PPE, personal protective equipment, and what to wear for each type of, microorganism, depending on the isolation precaution. And really, PPE is to contain pathogens or establishing aseptic barriers. Gloves, okay, that's our most common one. Masks, goggles, face shields, respirators, gowns, caps, shoe coverings, just to name a few. So we're going to go through our isolation systems next. And really all patients, okay, we're going to talk about standard precautions. So don't get confused by this type of precaution, but all patients are really considered standard precautions, meaning you're going to do whatever hand hygiene is necessary, and then typically wearing gloves, right? So this is a use for all patients, helps decrease the risk of transmission of bloodborne pathogens or other bodily fluids, whether it's undiagnosed or identified. And that's a big thing because some patients, we don't know what's going on with them. They're undiagnosed if there is some sort of pathogen. So that's why we provide standard precautions for all patients. So hand hygiene and wearing gloves are the two big ones just for standard precautions, and that's again on every patient. If there is a procedure that you think is a little bit more, that there's going to be some splashing of bodily fluids going on or splashing of blood, you can most certainly wear eye protection such as goggles or a face shield or a gown. So that is definitely okay to do. You're never wrong with protecting yourself. And then we're going to get into the next few slides of transmission precautions. So this is when the patient is a little bit more susceptible for transmitting diseases, either from, patient to patient it can be transmitted, or even from, healthcare provider to healthcare provider. So this is where isolation precautions come in. You see questions a lot on the NCLEX. They like to trick you a little bit, especially for like AIDS or HIV patients. What type of precaution? These fall under standard. You're doing hand hygiene and you're wearing gloves. There's really no special isolation precaution for them, and that sometimes gets tricky. So the first type of precaution we're going to talk about is airborne. Okay, is airborne precautions. What's airborne again? This is when microorganism either gets coughed, sneezed, or even by talking gets transmitted into air particles. And this is kind of the bigger one on the spectrum where those particles harbor for a long time in the air. They even become caught up in their dust particles. This is our special precaution where we need that what type of room? That negative pressure room, right? We need that constant airflow of bringing out the bad pathogen and taking it out of the room. So these patients need to have, their doors closed in that vacuum tight, negative pressure type of room. Isolation precautions for airborne, we'll see this on the next slide, but these patients will most definitely need a healthcare provider to wear what we call an N95 or a respirator. So that's a special type of mask that's going to create a nice tight seal around your face so that microorganism does not get in. Again, our most common airborne precautions are TB, and newer to us is COVID. So those are the two main things we really deal with airborne. And there is your N95 mask. And again, we talked about these. These needed to be fit tested. So making sure that it fits your face correctly. There's all different sizes of N95s. So I'm sure some of you who work in healthcare facilities have already been fit tested for N95s, but it's just a really important thing, especially if you're moving your head around. You don't want any type of leaks going on where that microorganism can enter. And COVID's a little bit different. It's one of its own, like we talked about in class, but I think going over COVID precautions is really important. You're just going to continue to see this. And I know we talk about donning and doffing in a little bit. But again, you're putting on a gown. So you're putting on a gown for COVID-19. You're putting on your N95. You're also putting on a face shield because remember we talked about mucous membranes are a big deal with COVID-19. So either goggles or a face shield were a big deal. And then you're finishing up with putting your gloves on. Next, we're going to go over droplet precautions, and this one was a little bit less on the spectrum compared to airborne. Do patients need a negative pressure room for a droplet? No, they don't, but probably more of what we call like just a private room, right? So we don't want to be bringing clean patients into a room with patient who is sick with the flu. So unless they have the same microorganism. So if there's two flu patients, they can most certainly be placed together, but we don't want to put a non-sick patient with the flu who needs droplet precautions. So we typically put these patients in private rooms, and they do not need negative pressure rooms. For droplet precautions, they need a surgical mask. So they don't need the full N95 respirator. A surgical mask is just fine for these. And again, this is the flu, common cold, rubella are the most common for droplet precautions. And there is your surgical mask. Next was contact. So this is probably your most type of isolation precaution you'll come across in the healthcare setting. Again, these patients should be set up in a private room because we don't want to be putting a clean patient in with a patient who has a microorganism on contact precautions, unless, again, they have the same bug. So if a patient there's two patients with MRSA, we can most certainly place them together. So the most common isolation precautions is C. difficile, MRSA, Mudro. We talked about VRE. That's another one you'll see quite often in the healthcare setting. And really, they'll need a gown and gloves for contact precautions. And here's your gown and gloves. And remember, I had you cross off the mask. I should not have provided a picture with someone with masks on. So cross off the mask. They need a gown and gloves for contact precaution. And this was a video. This was kind of your highest donning and doffing video, showing you really how to put on precautions for what would be probably a COVID patient. And the only reason I picked that is because you have the most PPE on, showing you how to don and doff all of these PPEs, right? So when donning, we're putting on our gown first. We then put on our gloves over our gown, right? Our gloves do not go underneath the sleeves of our gown. That's a biggie for me. Make sure those gloves go right over the gown and fit tightly, snugly over your gown sleeves. The N95 goes on next, and then lastly would be your goggles or your face shields. And then when doffing, gloves come off first, right? They're rolled into each other, thrown away. Same thing next is your gown. You're rolling your gown off your body, rolling it into each other, tossing that in the bin. And in between that, because we're going to touch our face next, you want to provide hand hygiene. After hand hygiene, you want to take off the face mask or goggles. And then after that, your N95 is removed. These are just some additional PPEs, especially if you feel that you need them. They're not part of standard precautions, but it's just something if you feel, especially we had the example of you'll have patients with either lice or bed bugs. A lot of healthcare providers feel a little bit more comfortable putting hair nets and booties on, and that you're never wrong in protecting yourself. Um, so we went over a little bit of labs. So PPE is done. I know you practice this a lot in lab, but lab values, what we look for, especially if patients are infected with some sort of microorganism, we tend to take what we call complete blood cell counts, right? CBCs. And really the main thing for these is we're looking at their white blood cell count, which is showing if our body's fighting off some sort of infection. Typically, white blood cells will be elevated. Normal ranges are 4,500 to 11,000 per microliter. Anything above 11,000 is elevation of white blood cells, or what we call leukocytosis. A next big one you're going to hear throughout your career is venous lactate. This is a really, really important lab value, which providers are really, really honing in on today and making sure that, infections are decreasing in our patients. We follow venous lactates. Remember we talked about kind of if you work out or if you have run or climbed a mountain or did anything, where your muscles may be a little bit sore or affected. The soreness in your muscles means that there's a buildup of lactate, right, in your muscles. Not always a bad thing, but that's why it's so important to hydrate, right, and kind of flush that lactic acid out. Kind of similar when there's a microorganism or some sort of inflammatory response infection in our patients. What goes on is we have a buildup of lactic, we have a buildup of acidosis within our patient when we have an inflammatory process. So remember, we have leaky capillaries, we have fluid coming out of our capillaries, decreasing our blood pressure, therefore decreasing our perfusion. Therefore, when our perfusion decreases, we have injury to our tissues. Venous lactate goes up. Normal venous lactates are below 2. Anything above 2 is a red flag. That's something we need to follow. And then we get to more of the severe point when we're getting our lactates up into the 4 region. We can check UAs. They can most certainly show infection, especially if we think there's a UTI going on. It can show us, if there is, any increase in leukocytes in the urine. Sometimes if there's a little bit more blood present or nitrates within the urine, that can most certainly show us that there's an infection. Blood cultures are big, right? We talked about these a lot, and that's kind of what shows what type of spectrum we can prescribe our patients for, providers prescribe our patients. So they're aerobic and anaerobic blood cultures. There's typically 2 sets needs to be done on different sets of the body. So for example, what a lot of nurses like to do is they take a blood culture set from the right arm and then they'll take another blood culture set from the left arm. So they'll need 4 total bottles. They need time to grow. They don't, come back right away. Sometimes 24 to 48 hours. We'll have our correct antibiotic. This can also be done with sputum cultures, urine cultures, also known as a clean catch, stool cultures or samples, and also wound cultures. And again, all of these need time to grow a little bit, but again, it'll find the correct source of the microorganism and help treat our patients a little bit better. There's further diagnostics. We can dig a little bit deeper and see more visual pictures of what's going on with our patients. But chest x-rays are always, a handy thing to have, especially if we think our patient has pneumonia going on, tuberculosis or TB. Bronchoscopies, they actually give us a little bit of better visual with a video. There's a little, video assisted catheter that can go down into the patient's airway, check out the lungs a little bit closer, see a better picture. They can also take samples of your lungs if needed. They can, do a CNS or a culture on portions of your lungs. Again, endoscopy gets a little bit deeper into the GI tract. You can see a little bit better picture there, especially if we're thinking something's going on more GI. CT scans are great. They can be contrast or non-contrast. Gives us more of a multi-dimensional image of certain parts of the body, and as well as MRIs, okay, magnetic resonance imaging. So again, how are antibiotics selected? And I think we've gone over this quite a bit, but we were taking these cultures. Those cultures are growing. Right off the bat, I know patients need antibiotics immediately. So you're like, well, how do we know what antibiotic to give, before cultures are done? So culture should always be drawn first, right? We talked about this in class. Cultures should be done before antibiotics. They're not going to alter, the spectrum of the culture. But most certainly a lot of providers put patients on what is called a broad spectrum. So once blood cultures or any type of culture has been drawn from the patient, we can start the patient at least on a broad spectrum to hopefully cover whatever microorganism it is. And then once that culture and sensitivity comes back, either 24 hours or 48 hours later, we can switch them to a different spectrum if needed. Sometimes we hit it right off the bat, other times not. So just know that cultures should always be drawn on the patient before antibiotics start, so the cultures do not get altered in any way. But these antibiotics, they help combat growth, they help combat replication of the microorganism, they help try to kill the microorganism and make our patients better. But as nurses, it's really important to monitor for any allergic reactions that may happen, especially if this is a new drug for the patient. Any organ toxicity, definitely kidneys, renal, also liver or hepatic. So our kidneys and our liver take sometimes a hit with antibiotics depending on what type of antibiotic it is and in the underlying diseases of the patient as well. And also interactions with other drugs. We should always be checking compatibilities and making sure that all medication will work together with the patient. And these are just commonly prescribed antibiotics. So there's amoxicillin, there's azithromycin, ciprofloxacin, cephalexin, trimethoprim, zosyn, vancomycin, acyclovir, doxycycline, Flagyl, just to name a few. I do not expect you to know all these. It's just good to see a visual. And once you get more into your clinicals, you'll be able to give some of these medications and you'll be giving them quite often. Vancomycin is very common. Zosyn is very common. Cipro. So you'll be seeing these a lot. And then lastly, we talked about therapeutic drug monitoring. So there we talked about avoiding toxicity within our patients and making sure that our patients are, handling these antibiotics well. And we don't want them to undergo any renal damage or liver damage or any toxicity for that matter. So this is why, drug peaks, peak levels and trough levels are very, very important to monitor in patients in certain type of antibiotics, not all of them. So when taking your peak level, which we really don't do too often, peaks are not as common as trough levels, but your peak level should be, this is your highest level of drug concentration, which is shortly after the drug is given. So right after the drug is given is typically when you take your peak levels. I really don't do this in practice a lot, so it's really not a common thing. But really taking trough levels is the most common. So that's, the lowest level of drug concentration, which really is just before a dose is due, you would take a trough level. And from there, you would see really how the drug is, how the patient is metabolizing the drug. Do we need to change the dosing of the drug? Do we need to make it less? Do we actually need to make it more? So it's really taking a look to see how this patient is metabolizing this drug. Does it need to be discontinued altogether? The most common type of antibiotics that need trough levels would be aminoglycosides, which is our biggest, our most common antibiotic would be vancomycin. So a lot of times you'll be drawing vanco troughs within the healthcare field, just to make sure that there's no toxicity, your patient is metabolizing the drug properly, and their kidney functions and liver functions are holding in okay. And that is all. Thank you guys for joining in on the voiceover. Thank you.